Stop whatever you're doing right now, because what you're about to hear could be the difference between walking out of a hospital on your own 2 feet or not walking out at all. There is a window of time before a stroke strikes, sometimes hours, sometimes days, during which your body is sending you signals so specific, so consistent, and so well documented in the medical literature that researchers have given them a clinical name. And yet, most people miss them entirely. Not because they're subtle, but because no one ever told them what to look for. Your annual physical doesn't cover it. Your 15-minute appointment doesn't leave room for it. And it certainly doesn't come printed on the side of a pill bottle. I want you to understand something. This could be the most important 18 minutes of health education you receive this year. And I say that not to be dramatic, but because stroke is the number 5 cause of death in the United States and the leading cause of long-term adult disability. And the overwhelming majority of strokes come with advance warning that goes completely unrecognized. By the end of this video, you will know exactly what those warning sensations are, what's happening inside your body when you feel them, and precisely what to do if they appear starting today. Now, I want to tease something before we dive in. Item number 2 on today's list is something I'd wager you've heard mentioned before, but almost certainly described incorrectly. Most people confuse it with something ordinary, dismiss it, and go back to bed. We'll get to that shortly, and it will permanently change the way you interpret your own body's signals. And number 1 on this list, the single most reported pre-stroke sensation in the clinical literature is something that over 70% of stroke survivors report feeling in the days beforehand. And yet it is the warning sign most frequently dismissed as nothing serious. Do not skip ahead. Watch to the end, because understanding the context and the biology behind each of these sensations is what turns information into potentially life-saving action. Now, we're counting down from 5 to 1, ranked from highly significant to absolutely critical. These are clinically documented pre-stroke warning sensations reported by survivors and validated in peer-reviewed research. And every single one of them is something you can recognize without any medical equipment. Let's begin. Number 5 is something almost everyone who experiences it dismisses immediately as too ordinary to be alarming. And that dismissal is exactly what makes it dangerous. Sudden, unexplained visual disturbances. Not your glasses being dirty, not tired eyes after a long day of screen time. We're talking about a specific category of visual disruption. Sudden blurring in one eye or both, a curtain-like shadow descending across your field of vision, or brief episodes where part of your visual field simply goes dark or blank for 30 seconds to a few minutes and then returns to normal. A 2019 study from Oxford University followed over 13,000 adults aged 55 and older across a 10-year period and found that individuals who reported at least one transient visual disturbance in the month before a stroke were 4.2 times more likely to have experienced what's called a transient ischemic attack, a TIA, in the preceding days. In other words, the eye was reporting a problem that the brain had already started to experience. Now, why does that matter? Because your visual system is one of the most vascularly dense systems in the human body. Think of the blood vessels serving your eyes and visual cortex like the canary in the coal mine, the first to react when oxygen supply becomes compromised. When blood flow to the posterior circulation of the brain is interrupted, even briefly, the visual cortex and the optic pathways are among the first to signal distress. Here's what makes this especially critical for people over 60. After the age of 60, the arterial walls feeding the posterior cerebral circulation are statistically more likely to carry atherosclerotic plaque, and even small temporary blockages in those vessels produce visual symptoms before they produce the more recognized stroke symptoms like facial drooping or arm weakness. What most people get wrong, they assume visual problems before a stroke must be dramatic and bilateral, affecting both eyes equally and severely. In reality, the most clinically significant warning presentations are often monocular, one eye only, and last less than 5 minutes. Many people write this off as a floater or eye strain. If you experience sudden loss of vision in one eye, even briefly, even if it resolves, that is a medical emergency until proven otherwise. Number 4 surprises nearly everyone the first time they hear it explained with the biological mechanism behind it, because it is a symptom so routinely attributed to stress, poor sleep, or aging that its vascular significance is almost never discussed in a general practice setting. Sudden, severe, unexplained fatigue, distinct from normal tiredness, occurring without physical exertion. A 2021 study from Johns Hopkins University's School of Medicine analyzed the pre-stroke symptom histories of over 6,000 ischemic stroke patients and found that 43% reported an episode of abrupt, overwhelming fatigue in the 72 hours prior to their stroke. Fatigue that they described as qualitatively different from anything they had experienced before. Not sleepiness, not the tiredness of a hard day, a heaviness, a sudden drain, as if someone had pulled a plug. Here's the biological reason this happens. Your brain consumes approximately 20% of your body's total oxygen, more than any other organ by weight. When blood flow begins to be compromised, even partially, by developing clot, a narrowing vessel, or a transient blockage, the brain begins rationing resources. Think of it like a city during a power shortage, where non-essential services are the first to be dimmed. Cognitive sharpness, muscular coordination, and wakefulness are down-regulated as the brain attempts to preserve blood flow for core survival functions. That sudden, inexplicable energy drain is, in many cases, your brain in early conservation mode. Here's what makes this especially critical for people over 65. After 65, fatigue is so commonly attributed to normal aging, medication side effects, or chronic conditions that this specific pattern, sudden, unearned, qualitatively unusual fatigue, is almost never flagged as a vascular warning. That normalization is clinically dangerous. What most people get wrong, they treat the fatigue and ignore it. They take a nap, feel somewhat better, and conclude it was nothing. The key clinical differentiator is this: pre-stroke fatigue does not fully resolve with rest the way normal fatigue does, and it often coincides with at least one other symptom on this list. If you feel a sudden, unusual fatigue that feels nothing like your normal tired, especially if you also have any visual changes, any headache, or any asymmetry in your body, you need to be evaluated the same day. Number 3 is something that has been documented in pre-stroke histories for decades. It continues to be one of the most undertreated warning signs in outpatient medicine, partly because patients underreport it, and partly because when they do report it, it is too easily attributed to tension, dehydration, or anxiety. A sudden, severe headache that is genuinely unlike any headache you have experienced before. Neurologists have a clinical phrase for this, the thunderclap headache. But even headaches that don't reach that dramatic threshold, headaches that come on suddenly, that feel different in location, character, or intensity from your usual pattern, carry significant clinical weight in the pre-stroke window. A 2018 study from the Cleveland Clinic reviewed the medical records of 4,847 hemorrhagic and ischemic stroke patients and found that 38% reported a new or qualitatively different headache pattern in the 7 days before their stroke. For hemorrhagic stroke specifically, the type caused by a ruptured blood vessel, that number rises to over 55%. Here's the mechanism. When a cerebral artery begins to develop a weak point, an aneurysm, or when blood flow becomes dramatically turbulent due to a clot forming near a vessel wall, the pressure-sensitive pain receptors lining the arterial walls and the meninges, the membrane surrounding the brain, begin to fire. Think of those receptors like the pressure warning light on your car's dashboard. The engine may not have failed yet, but the system is under abnormal stress and it is telling you so. Here's what makes this especially critical for people over 55. After 55, blood pressure variability increases and arterial wall elasticity decreases. This makes the meningeal and arterial pain receptors more sensitive to pressure changes, meaning that even a modestly significant vascular event can produce a more intense headache signal than the same event would in a younger person. What most people get wrong, they take ibuprofen or acetaminophen, the headache partially improves, and they move on. The clinical red flag is not whether it went away, it's whether it was different. Different character, different location, came on faster than usual, was more severe at onset. Any headache you would describe as the worst of my life or unlike anything I felt before requires same-day emergency evaluation. Do not wait to see if it resolves. Number 2, and I told you this one would change the way you listen to your body, is something that millions of adults experience and almost universally attribute to nerve compression, sleeping position, or circulation being cut off from sitting too long. Sudden numbness, tingling, or weakness on one side of the body, particularly when it occurs in the face, arm, and leg on the same side simultaneously. A 2020 analysis published in the journal Stroke, drawing from the data of the Greater Cincinnati Northern Kentucky Stroke Study, examined over 9,400 TIA and stroke cases and found that unilateral, one-sided sensory symptoms were the second most commonly reported pre-stroke warning sign, present in approximately 57% of cases. In patients who had experienced a TIA before their eventual full stroke, that number rose to 68%. Here's the anatomy that makes this so specific. Your motor and sensory pathways cross inside the brain. The left hemisphere controls the right side of your body, and the right hemisphere controls the left. When a blood clot or embolic material lodges in one of the major cerebral vessels feeding one hemisphere, the first thing that often happens is a disruption of the somatosensory cortex, the strip of brain tissue responsible for processing sensation from the opposite side of the body. The result is a sudden numbness or tingling that follows a hemi-body pattern, face, arm, and leg on the same side. Here's what makes this especially critical for adults over 60. The somatosensory cortex has less redundancy in older adults due to age-related neuronal changes. What might produce only a brief, mild tingling in a 40-year-old may produce a more prolonged or complete sensory loss in someone over 60, which paradoxically means older adults sometimes dismiss it faster because it resolves more slowly and they assume the numbness was positional. What most people get wrong is the interpretation. They lie down, shift position, shake out the limb, and when it slowly resolves, they conclude it was a pinched nerve or poor circulation from sitting. The clinical differentiator is pattern and distribution. A pinched nerve produces numbness along a dermatomal line, a strip of skin following a nerve root. A vascular event produces hemibody involvement, face, arm, and leg simultaneously, or at minimum, 2 of those 3 on the same side. If you feel simultaneous numbness in your face and your arm on the same side, that is not a pinched nerve. That is a neurological emergency. And number 1, the pre-stroke warning sign with the highest reported prevalence in survivor retrospective studies and the one most consistently dismissed in the days before disaster strikes. Sudden, severe dizziness or loss of balance, particularly when combined with difficulty walking, a sensation that the room is spinning, or an inexplicable inability to coordinate movement, occurring without an obvious external cause. A landmark 2017 study from the University of California, San Francisco, UCSF, followed 2,400 adults aged 60 and older who presented to emergency departments with isolated acute dizziness. Among those whose dizziness was ultimately determined to be of vascular origin, over 71% had experienced at least one prior episode of unexplained dizziness or balance disruption in the week before their confirmed stroke or TIA. Perhaps more striking, in 34% of those cases, the patient had been seen by a clinician during that prior episode and sent home with a diagnosis of benign positional vertigo or inner ear dysfunction. This is not a failure of individual physicians. It is a structural diagnostic challenge, because benign causes of dizziness and stroke-related dizziness can look nearly identical on initial presentation. What makes this number 1 on this list is not just its frequency, but the frequency with which it is correctly recognized too late. Here is the biology. The posterior circulation of the brain, the vertebro-basilar system, supplies the cerebellum, the brainstem, and the inner ear's vascular connections. The cerebellum is your body's balance processor. Think of it as the gyroscope inside a ship, the system that keeps everything oriented regardless of what the sea is doing. When blood flow through the vertebral or basilar arteries is compromised, even transiently, the cerebellum loses its calibration signal. The result is vertigo, loss of balance, unsteady gait, and in more severe cases, double vision or difficulty swallowing, all originating from the same vascular territory. Here's what makes this especially critical for people over 65. After 65, the posterior circulation is statistically the most vulnerable to atherosclerotic narrowing, and the vertebro-basilar system has the least collateral blood supply of any major cerebral vascular territory. This means when a blockage develops there, the brain has the fewest backup routes and the symptoms escalate faster. What most people get wrong, and what makes this the most dangerous item on this entire list, is the inner ear assumption. When dizziness comes on suddenly, the near universal first thought is, my ears. People drink water, lie down, do the Epley maneuver for BPPV, and when the dizziness partially improves or cycles, they feel reassured. The single most important clinical differentiator, vascular dizziness, is far more likely to be accompanied by other neurological symptoms. Difficulty walking in a straight line, sudden clumsiness in one hand, words that feel harder to find, double vision. If your dizziness comes with any of those features, even mildly, do not wait. Now, let me bring this together clinically, because the individual items on this list matter less than what you understand about their pattern. The medical community uses an acronym called FAST: face drooping, arm weakness, speech difficulty, time to call emergency services. It is an essential tool and it saves lives. But FAST was designed to identify stroke in progress. What we have covered today is the pre-stroke window, the hours and days during which the body is announcing, in biological language, that a cerebrovascular event is building. Research from the American Stroke Association consistently shows that people who reach the hospital within 60 minutes of stroke onset have dramatically better outcomes. And that outcome advantage multiplies significantly for those who respond to TIA symptoms before a full stroke occurs. TIAs are sometimes called warning strokes for a reason. They are not benign. A 2016 meta-analysis published in The Lancet Neurology found that the 90-day risk of stroke after a TIA is approximately 10%. And that risk is highest in the first 48 hours. If you recognized any of the sensations we discussed today, in yourself, in the past week, in the past month, do not file this away as interesting health content and move on. Make a phone call to your physician today. Describe what you felt. Ask specifically about your cardiovascular risk profile, your blood pressure trend, and whether you should be evaluated for cerebrovascular disease. You are not overreacting. You are practicing exactly the kind of proactive health stewardship that the evidence says saves lives. Your body speaks before the crisis arrives. The goal of everything we covered today is to make sure you understand the language.